online this morning. He lectures in pharmacology at Wits University and always available to share important information with us. Neil, morning. Welcome to the program. So good to be talking with you again. Neil, are you there? Hello? Hello? Neil, can you hear me? All right, we seem to be having a faulty line, and while Milazi Boy sorts that out for us, let me just remind you that in a short while we'll also be talking with economist and former financial journalist Duma Ngubule about the impact of the second wave on the South African economy, obviously. And so we want to hear about that. But right now we do have Dr. Neil Butkow online. Neil, morning. Welcome to the program. Great to have you here.
You too, Julie. Always nice to talk to you.
Thank you. Now, obviously, we're going to be talking COVID-19, the second wave, and everything that goes with it. I had a wonderful chat with Dr. Martin Gill yesterday. He's an ENT specialist based at Life Four Ways in Johannesburg, and he's an advocate of ivermectin. So we've kind of talked at length about that. I know you have slightly differing views on ivermectin. Time permitting, we will touch on it. And, you know, with due respect to everybody, they are entitled to their own views. Let's start by talking about the second wave. Again, there's differing views. There's certain schools of thought that believe that it is more contagious, for want of a better word. Is that in fact true? And why are we seeing this new variant? What has gone on or what has gone wrong that we are hit by the second wave?
I guess there's lots of answers to that one question. The problem with this virus is that, as you probably know, it's easily spread by droplets and by aerosolized, little droplets that can be easily taken in. And I think the problem is that, for every one person that has got COVID, there's the ability to infect 2 or 3 other people without really giving them symptoms, for maybe some time. So, highly contagious, spread easily, got an unknown. Often many people don't show any kind of symptoms. So people can walk around and, not have symptoms, but could still be spreaders. So, they always talk about the second wave coming. I'm surprised that it came so early. But given the fact that I think that we were not being diligent for a long time in sort of November, December, and then we had, some super spreading type of event, I think it's only to be expected at the moment.
Let's talk about those people who are asymptomatic. You indicated that they're not even aware that they are walking around with the virus. How dangerous are they to the people around them? Because let's assume I'm asymptomatic, is it, my spread that much more dangerous than someone who presents with the symptoms?
Well, exactly, because if you at least present with symptoms like the high fever, the cough, the fatigue, the body aches, all that type of thing, you can self-isolate under those circumstances. But if you're not showing any kind of symptoms, how do we know? The only way to really know is to have a PCR test of the actual COVID virus itself. Of the SARS-2 COVID virus. So, and those tests are expensive, and,
absolutely.
there is a shortage of those type of tests. Is there a difference in the contagion in South Africa? I don't think that has been realized at the moment. But what I did read yesterday is that there's already 2 variants that are making their way through, the Earth's population. I think they're called the S and the L variants. But the thing is that mutations are common in these type of viruses because, viruses get into our cell machinery and use it and hijack it. And when they make copies of themselves, they often make copies that are not exactly the same as the one before. And that some of these copies may die because they may not be as viable as others, but others may be actually even more viable than the parent one. And so, that is going to be translated into a new variant. And if that new variant has got a higher contagion type profile, it's going to cause problems in the community. Now, what we've got to do, especially with things like vaccines, we've got to make sure that the vaccines can stop the transmission of the virus no matter what the variant is. And that's part of the problem.
So we don't even has the variant been identified? Because that would then obviously assist the pharmas, the big pharmaceuticals, in adapting the vaccines that they've already produced. Do they know what these variants are and how they should be addressed?
Not in localized regions like in South Africa. I mean, that work came from Wuhan itself, where they found there were two variants that were circulating. So it's going to be, it's going to take some time because, I mean, where do you start looking at these different variants? Then what you have to do is you have to take the virus and sequence all its genes and compare it to other viruses and to see which is the main virus. I mean, you can see a similar type of thing with HIV. There's at least two major clades called the B clade and the C clade. The C clade is found mainly in Africa. The B clade is found mainly in the USA. I mean, they're the same disease, but they've got different variants. And so, and the C clade is much more virulent than the B clade of HIV. So there are important differences, but we don't know if those differences are, structurally important for the spread of this disease, for the lethality of the disease. We don't know any of that stuff, Julie.
But that also then suggests to me that the people with different variants need to be treated differently.
Not really, because
I mean, medically. I'm talking medically. Maybe their meds, maybe higher doses or a different type of med, etc.
It's unlikely that we would be able to isolate them to such an extent that they would be treated different. I mean, the treatment nowadays is just supportive and symptomatic. And so that is the symptoms then are going to demand different types of treatment. So if a patient shows with a fever and respiratory distress and whatever, they're going to be treated the same way, whether they've got this variant or that variant. It really doesn't matter. So it really is how the patient presents, which is actually more important.
Okay.
But I think...
Carry on.
I want to burst your bubble about ivermectin, but you can ask me that later.
We'll leave that. We will put that in the parking lot for now. Neil, what about somebody who I'm looking at your protection phase. If I presented with COVID-19 3 months ago, for example, and it doesn't matter how severe or mild it was, for how long do I have supposed immunity even without having been vaccinated?
Yeah, well, I mean, the body does mount a antibody response, and that's the whole point of antibodies, because what will then happen is that you will then have in your plasma these things called antibodies, which are very, very specific for the actual virus. So you get antibodies against, all the viruses that we are infected with, like chickenpox and measles and rubella and diphtheria and all of those type of things. We generate these things called antibodies. But also what we've done is that there are T cells, there are lymphocyte cells that carry the memory of these type of pathogens for a very long time. Now, I don't know if there's any major work to show whether T cells have been primed in that way, but we do know that immunoglobulins are produced, and they probably produce for about 3 to 6 months afterwards.
So is that your protection period, so to speak?
So yeah, but it is troubling that some people have had COVID, and then a couple of months later had it again.
Mm.
You know, is that another variant? Is it just the same disease? You know, it's still too early to actually say about all of that type of thing. So, you know, I mean, at the moment, Julie, you know, just take whatever precautions you can. I mean, wear your masks, with, you know, especially around people that you don't know. You know, if you go to the shops or restaurant or whatever, you know, before you start eating, just wear your mask. I mean, it is the most powerful preventative measure that we've actually got, you know, and don't use it as a chin warmer. It's really not useful.
Okay, we're going to get to vaccines in a minute or two, but there's been certain medical professionals, and there's these YouTube videos making the rounds. There's an American medical professional who is really touting the importance of vitamin D. Talk to us about that in the fight against COVID-19, obviously.
You know, this is also just what the Americans would say would be circumstantial evidence. So the circumstantial evidence here is that vitamin D levels are often quite low in COVID patients, but most of us actually have very low vitamin D levels. And it isn't clear about whether if you give vitamin D that you're actually going to stop the infection or prevent the infection from spreading. So that is still very, very early. So what they're doing now is they're just saying, take vitamin D because we don't know if it's going to be, you know, to protect you or not. So it's unlikely to have any major side effects, vitamin D, which is good. But then they're also, you know, proposing a whole lot of other things like vitamin C and zinc and selenium and, you know, I mean, and vitamin Bs and all types of other things. None of these things are actually what we would call evidence-based, you know, and I've been looking very carefully at the literature, and there's no sort of very clear guidelines, you know, and even some, you know, very profound scientists are taking these type of combinations because we just don't know. And, you know, it's sort of a shotgun type of approach.
Okay, there's also some more information doing the rounds as we speak. And there is talk about low viral loads. How it in high or low, you know, if you've got high viral loads, how it influences, you know, your exposure or how it influences the, you know, the COVID-19, you know, spreading possibly or making you really very sick. Explain this whole viral load scenario to us.
Well, it's based on the fact that, you know, the higher the viral load that you're exposed to.
Meaning what?
Meaning if there are lots and lots of viruses in the little droplets that you inhale, you're more likely to get sick and you're more likely to be overwhelmed by the actual virus because there are so many viruses and there are so many targets for them to actually connect with that they can overwhelm our defenses almost immediately. With a lower viral load, you've got the ability to then activate some intrinsic type of mechanisms that can then cope with the lower viral load, and then you might also not even develop the disease or you may clear it. So, you know, that is why the masks are so important because they stop those droplets, those big droplets from actually spreading and getting into, you know, into our sort of mucosa. Because any of the mucosa in our nose, our mouth, but especially in our lungs, are targets for the SARS-CoV-2 virus.
I make the next statement very tongue-in-cheek, but I'm sure that there's a lot of merit in what I'm going to say, and that is, you know, for people in relationships, I should imagine kissing is off the table.
Yeah, especially if it's a frog that's infected. I wouldn't kiss any frog.
No, I mean, seriously.
No, of course. Well, you know, if one person in the partnership has got the actual disease, I mean, they should be isolating themselves from the rest of the family. I mean, which means no sort of,
you know what, Neil, I'm
Yeah.
thinking whether you have the disease or not, just as a precaution in these very, very trying times, there are just certain practices one should not be indulging in. But like I said, it is tongue-in-cheek, but it is serious enough. It makes so much sense.
For sure. You know, and would you kiss someone who's got a cold?
No,
you know?
absolutely
would you
not.
Kiss someone who's got not HIV, but let's say who's got the flu virus, or anything like. Would you kiss them if they have measles or mumps or whatever? You wouldn't. You wouldn't do any of that stuff. So here's, if you're positive COVID or whatever, and you're not showing any kind of symptoms, self-isolate for a minimum of about 10 to 14 days. And if you don't develop anything, then you can start, holding hands with your partner or whatever.
All right. Coming back to the viral load issue, there's also this suggestion, and I've been seeing lots and lots of messages in suggesting that whether you're sick or not, that try and practice this on a regular basis is to steam, because the suggestion is that the virus sits at the back of the nasal passage for the first 2 or 3 days. So if you do nasal irrigation, or if you steam regularly once a day, if you're not feeling sick, and once you do have, the symptoms, that you should probably steam 3 or 4 times a day with some sort of menthol addition to the water and so forth. Your thoughts on it?
I don't know. I haven't really seen anything like that.
Does it make sense to you? I mean, you are the scientist. Does that make sense to you?
Well, I mean, mild steam is actually the best sort of therapy for bronchitis. It's more effective than cough mixtures and all of that type of thing. But it's doing a different type of effect there. It's what it's doing is causing some bronchodilation and suppressing some of the mucus that is produced in the lungs. So that is the understanding about that. Whether the steam, can actually stop the virus from actually entering
your lungs. Yeah, apparently it's in the back of your nasal passages, and after day 3 or 4, then it progresses to your lungs, and that's when all the complications start.
Yeah, but I mean, I would be loath to actually try something like that if I knew for sure that that I had COVID or whatever, and unless I actually had respiratory distress in any type of way. But they do talk about lowering the viral load, exactly like you say, but there are different ways of doing it. There's also saline sort of washes that can also do that, lowering your viral load, your nasal viral load, so it doesn't get into the lungs, or when it does get into the lungs, it's much lower concentration.
Okay, and that's exactly what I was referring to. Let's talk about we've been told about the vaccines, and we are waiting in anticipation for the vaccines for government to get off its hands and, do the necessary so that we in South Africa can get our hands on the vaccine sooner rather than later. But I understand that the vaccines were, when in the trial phases, was tested on adults over the age of 18 years of age. What about under 18s? And we're also being told that this new variant is impacting on children as well. Children are also presenting, possibly not as severely, but also presenting with symptoms of COVID. Your thoughts?
It's going to be very difficult to get data from using children as medical subjects. They're just not going to be used for that unless a breakout of the disease in kids and they have to do something. So we're not going to be able to use that as any kind of a technique to find out whether we should be inoculating children or not. Let me just clear what you're saying. It is not one vaccine. There are maybe 20, 30, maybe even up to 50 different candidates, all being tested at different stages. There's one which is has enrolled, I think, between 10,000 and 20,000 people. It's only going to end in July 2022.
Oh.
Yeah. So and they're still recruiting and they're still doing all of that type of thing. How will we know, which one is the best? We won't. So when you say, is government doing something? Which vaccine are you talking about? There's so many different candidates. They're looking at different things. They're looking at different ways of how to, introduce, some kind of a killed virus into the human being so that it doesn't also cause a major problem, in humans. So, the safety and the efficacy of those studies are still very much in its infancy.
But it's better, I should imagine, rather get the vaccine than not having it at all. Even if you're covered 50% by the vaccine, it is still some form of protection.
Well, 50% doesn't mean that you've only got 50% of your response. It usually means that only 50% of the population, are actually protected.
Exactly.
And so, maybe you have to get to figures as high as about 80 to 90% to really have the whole of the population really protected. And remembering that, that there are going to be people in that population group that have been exposed and have got their own natural immunity. So, that's also, in some ways, what's happening at the moment is that we are getting people that have got natural immunity to the disease, and they are in the sort of environment. They're in our population groups.
Mm-hmm. Neil, unfortunately, we've run out of time, so we're not even going to touch on ivermectin. And I promise you, I'm not sidestepping you. We'll have you on air once again to talk about ivermectin and a whole host more. But thank you indeed for being with us on the show.
Pleasure.
Take care, and till the next time.
Discover the Africa of your dreams and surround yourself with his